Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gollin.
Welcome back to the Gastro Girl podcast. I'm your host, Jacqueline Gollin, and this is the third episode in our special four-part series focused on GERD and Barrett's esophagus. It's sponsored by Castle Biosciences and brought to you in collaboration with expert clinicians and researchers dedicated to improving patient outcomes. In episode 2, we learned from Dr. Muthuswamy how Barrett's esophagus is diagnosed, how endoscopy plays a key role, and how advanced testing like tissue cipher can help assess a patient's personal risk of progressing to esophageal cancer. Today, we're taking the next step, learning how to manage and treat Barrett's once it's been identified, especially in patients at higher risk of developing cancer. I'm thrilled to welcome our featured expert guest, Dr. Houghton, a surgeon with Keck Medicine of USC who specializes in minimally invasive foregut and general surgery. Welcome, Dr. Houghton. It's so great to have you on the show today.
Well, thank you for having me. I really appreciate your platform and how you're getting information from experts to patients. So it's really an honor for me to be here today.
Oh, thank you so much. So this is part of a four-part series that's brought to us by Castle Biosciences. And we've had some amazing guests on all the episodes so far, like yourself. So for those who may be joining in, starting with this episode, can you help us set the stage for our discussion today and maybe help us recap what we learned in the last episode and how it relates to today's conversation?
Yeah, so Barrett's esophagus is usually diagnosed with an endoscopy. So patients will get an endoscopy. Often they'll get biopsies. And then once you have a diagnosis of Barrett's esophagus, we have to kind of understand the risk of that patient so we can recommend the next step of therapy. And that often involves one, sending biopsies out for a test called tissue cipher, which can stratify risk for patients. So it can tell us whether they're at low risk of progression to cancer or high risk of progression. And that can change whether we're going to do surveillance endoscopies at an interval of 3 to 5 years, or if we're going to recommend something like endoscopic eradication therapy, which is, I think we'll get into a little bit more as we have this conversation, but it's ways that we can endoscopically treat Barrett's to try and get it to regress.
Now, it's so fascinating when you talk about the risk stratification, and that's basically talking about, like you said, patients who have been diagnosed with Barrett's esophagus, and then the next step is figuring out their risk and using the tissue cipher. Now, is that part of the protocol, or is this something that a patient would have to ask for, or how does that work?
So tissue cipher is a newer tool for us to use, and it's catching on. More and more gastroenterologists and surgeons are using it as an adjunct to risk stratify patients, but not every clinic has it yet. What every clinic will do is they'll take the biopsies, and then if they are sending them out for tissue cipher, then we will send those out and get a score, and it will tell us whether a patient has a low risk of progression or a higher risk of progression. And this is really important because prior to having this test, we were really only classifying by the typical biopsies on whether they had any distortion of the cells on the biopsy. So was it dysplastic? So you either had the non-dysplastic Barrett's, which was classified as low risk, or a dysplastic Barrett's was classified as higher risk. But what we noticed is that some patients with the non-dysplastic type of Barrett's did progress. And it's those patients that really we want to know who should we be intervening on a little bit earlier. And that's where a tissue cipher comes in, because we can send those biopsies. And if it tells us that they're higher risk, we can escalate their care and their treatment plan and maybe prevent a progression that we may not have known would progress if we hadn't had that test.
That's amazing. That's huge news for patients. That's why we love interviewing experts like yourself on the show, because a lot of times doctors find out information from their patients who go to them with, I heard this on such and such, and here's some evidence. Can we look into this? So I'm really glad you brought this to our attention today, because it is important for patients to know about this tissue cipher. So if they're in that position, or a loved one is, they can ask their gastroenterologist before, so they feel like they have peace of mind. So this is great news. Thank you.
Yeah, the other thing that's nice is that a biopsy that's taken even in a previous endoscopy or previous procedure can be sent out for tissue cipher if they can get it from the pathologist.
Oh, wow. So you mentioned, this is a mouthful. I'm going to try it. Endoscopic eradication therapy, otherwise known as EET. When is that recommended? What is that, and when is that recommended?
So that is recommended for our higher risk patients. Anyone with dysplasia, which is a change of cell type, and anyone now that may have a high risk non-dysplastic Barrett's. So anyone we're considering as high risk for progression to esophageal cancer, we want to get ahead of that and really intervene early. So there's two types of endoscopic eradication therapy. One is RFA, or radio frequency ablation, but RFA for short. And basically that's burning the tissue off. So we basically can go in there, look at the area of the lumen or the mucosa in the esophagus that's injured, and we can burn that away. And then the tissue that typically regrows is normal tissue. The second eradication therapy that we can do is called EMR, and that's endoscopic resection, mucosal resection. So that's really used for anyone that has a nodule or a raised area of Barrett's. And with that, you can basically cut out a section of the injured area of the esophagus. And it's a different way of getting rid of that tissue, whereas burning might on a lumpy area might not be as effective. So we have to cut that out instead.
Now, I know we're talking about GERD as a precursor to Barrett's, but this is making me think now, are there any other conditions or things that may cause Barrett's besides GERD? Or is there any other things that may impact it?
Yeah, we think patients that are higher risk for developing Barrett's esophagus tend to be male, not always, but tend to be male. They tend to be over 50 years old. And then they can some have a smoking history. Those are kind of the three things that we think about that are not related to acid reflux. And then family history as well. If you have a relative that had Barrett's esophagus, then we think a little bit more about it. But then in the acid reflux side, the reason why acid reflux is considered the precursor to Barrett's is because it's really a reaction to injury. And it's not only a reaction to the injury of acid coming up from the stomach, but it can also be gastric juices that contain bile and gastric enzymes. So anything from the stomach that's refluxing up into the esophagus can cause injury. And a hiatal hernia predisposes you to have a weakened valve that would protect you. So if you have a hiatal hernia, you're more likely to have acid reflux. And then that acid reflux or any reflux from the stomach can create injury, which leads to Barrett's esophagus.
So it's so fascinating how everything just impacts. You don't think about all these things. So I really appreciate your bringing that to our attention, especially other factors that may impact that. Now, going back to EET, you notice I use the letters.
Yes. Easier to say for sure.
Yeah. Can you walk us through what a patient might expect, timeline, recovery, and possible side effects or things that may happen after the procedure?
The most common one is RFA. Most commonly, Barrett's is a flat lesion. It's a flat area. And so the most common thing we do is RFA, or burning it off. Usually we have to do that in several sessions. So it might take usually 2 or 3 sessions to get it completely to go away. And So we'll come in, we'll do an endoscopy or a scope down the throat so we can see the area. We'll then burn the area off with RFA. And then the patient will go home. And usually those sessions are spaced out about 2 months so that we have time for some new tissue to heal, or that burned area to heal a little bit. So then we can see what's left over. And that may take 2 or 3 sessions to completely resolve Barrett's. Patients tolerate that pretty well. There's maybe minimal pain from the scope, maybe a sore throat. We tend to send patients home with what we call a GI cocktail. It's some antacids and some liquid pain medications, just in case they have some irritation. And most do have some, so they'll have to take that for a couple days. But other than that, patients tolerate it really well. The side effect profile is also pretty low. You can get strictures, meaning that when the area heals, it kind of heals almost too much, and it can create some scar tissue that can narrow the lumen. And then if that happens, we can intervene endoscopically with a dilation. But other than that, there's not a lot of other side effects. EMR is similar. EMR is usually a one-time thing, though. We can usually get that raised area out in one session. And then again, the post-op and the complications are about the same.
Thank you for explaining those. Now, how effective is EET at preventing cancer progression in high-risk patients?
The good news is that it is very, very effective. It's 75 to 90% effective for eradicating Barrett's esophagus and kind of eliminating that progression to esophageal cancer. What I always say is we really want to catch it early, because what we don't want is to catch it at a later stage where we can't do eradication therapy. And there's a long time usually between when you get Barrett's and when it progresses beyond what we can do endoscopically to a surgical intervention, like for something of esophageal cancer. And so it's very effective. It works really well. There is a failure rate to this. So it is 75 to 90% effective. However, it can come back. And when it does come back, some of them come back as that lower grade, like non-dysplastic Barrett's, which we're not as concerned about. And then about 15 to 20% come back with some disorganization of the cells or dysplasia. And the patients who tend to come back are those that have a larger hiatal hernia or are not getting the acid reflux control that we need in order to prevent the injury.
Now, is there a surveillance that you recommend, like follow up with the doctor to kind of see how things are going? Is that typical for these patients?
Yeah, that's very typical. So patients with Barrett's, depending on the risk, how high a risk they are going to either have a shorter surveillance as short as 6 months. And then if their risk is downgraded, then it can be spaced out to 1 to 3 years and then 3 to 5 years. So they are almost always surveyed, though, for life. This is something that once you have a diagnosis of Barrett's, you're really wanting to touch base with a physician regularly, and we never really let you go.
Yeah. And you mentioned that whether or not a patient receives this procedure, EET, or that controlling acid is essential. And can you explain why that is?
Acid or any reflux from the esophagus or from the stomach into the esophagus is really what's causing the injury in the first place. So we want to make sure that once we eradicate the Barrett's and it heals, that we've also then eliminated the factor that's going to cause or recause the injury. So if some patients can do that well with antacid medications, and that works beautifully for a lot of patients, and they can take antacids and that will control their reflux enough that they won't have ongoing injury. However, like I think I mentioned, patients with larger hiatal hernias, which means part of your stomach is in your chest, that displaces or that weakens the valve or the barrier between the esophagus and stomach, and it kind of makes it so that it's open all the time. So in those patients, it's harder to control the reflux, what's coming up and injuring the esophagus. And so in those cases, sometimes surgery is necessary to help control the reflux so that once they're treated and the Barrett's has regressed, it doesn't come back.
No, that makes a lot of sense. Sometimes we don't think about it. Sounds so easy, but a lot of times we're not paying attention to that, and we're just dealing with it daily.
Right.
So thank you for explaining that. With that said, like, what are some of the effective ways, in your opinion, as an expert, to manage reflux day to day? Like, what would you talk to your patients about?
Yeah, there's a lot of lifestyle changes that you can do that can help prevent reflux from happening. And those are things like avoiding trigger foods, a lot of the things you like want to eat, such as coffee, chocolate, fatty or greasy foods. Those can all be triggers for acid reflux. A lot of times we want to make sure that you don't eat too close to bedtime, especially if you might have a weakened valve, which is most patients that are having reflux have a little bit of weakness to their valve or their barrier between their esophagus and stomach. So we will say that they should eat maybe 3 hours before bedtime, maybe keep their bed inclined a little bit. And then if they're taking antacid medications, to take those on a regular basis. Those interventions work really well if your valve is structurally pretty intact, but maybe a little weak. But if your valve you have a big hiatal hernia, or your valve is really weak and disrupted, that's where a surgeon will come in, because even if you do all those lifestyle changes, that valve is so open that you might change the acidity, but the gastric juices are still going to be able to wash up and cause injury.
So what strengthens that valve? I mean, we can't give it a weight to kind of like
I know.
do some valve curls or something like
Right.
And maybe it is a surgery, and just trying to visualize like what is done to maybe strengthen that, or to help not have it so open.
Yeah, so it is most of the time it's a surgical intervention, especially if there's a hiatal hernia component, because the valve is in the wrong place. So first we need to get it into the right place. And so that requires a surgical intervention. It's small incisions, I use the robot, so it's really gentle. Yeah, and then we go in, we make the small incisions. I always tell patients we kind of dissect around the esophagus and stomach so that we can pull that stomach down below the diaphragm into back into the abdomen, and that'll put the valve in the right place. And then we do what's called a fundoplication. Nice fancy word again, for basically wrapping the stomach around the esophagus to create a cuff or a valve. And when we do that, it reinforces the natural valve and then prevents acid from being able to go up into the esophagus and continue injuring it.
That's so fascinating, the use of the robot. I mean, how cool is that? Your kids must think you're so cool.
Yeah. When they were little, they thought I was really cool. They kind of thought of it as a droid from Star Wars. So they kept asking me to meet it. They were really excited to meet my robot.
So awesome. I love it. And I know I kind of digress a little bit, but I know there's some other lifestyle factors, weight. Can you talk about those? And vape. So many people smoke and vape these days, and then just other things like hydration and tight clothing. Can you talk a little bit about those?
Yeah. So weight is a factor because it increases intra-abdominal pressure. So if you carry more weight in the abdomen, then it can kind of cause some pressure to cause the reflux to go up. Smoking, again, just can injure that area and weaken the whole system and make it difficult to. Makes it more prone to injury, actually, is what it's doing, is making the esophageal tissue more prone to injury if you smoke. Tight clothing, I think, is one that probably has the least data around it. I think people feel uncomfortable. They feel like the bra straps feel tight, or tight clothing can feel uncomfortable. I don't know if it changes whether you have reflux or not. And then the hydration just kind of can kind of especially after eating, can kind of help flush things through so that you kind of keep the stomach clear so that hopefully not as much will come back up.
Oh, interesting. Now, you kind of alluded to this because we were kind of going back and forth, but when medication and lifestyle changes aren't enough, I'd like to, really understand and help our listeners understand what surgical options are available to treat the reflux.
So the surgical options typically include a hiatal hernia repair if you have a hiatal hernia, but some patients just have a weak valve and they don't have a hiatal hernia and they need the fundoplication, or the reconstruction of the valve. So if you have a hiatal hernia, we're doing both. We're doing a hiatal hernia repair and a reconstruction of the valve. If you just have a weakened valve, we can just reconstruct that valve for you. And if you don't have a hiatal hernia, there is actually an endoscopic option as well. We talked about endoscopy for treating Barrett's. There's actually also an endoscopic way of reinforcing that valve if you don't have a hiatal hernia. If you have the hiatal hernia, we definitely need to go in and get the valve in the right place before we fix it.
Great. And you also mentioned a Lynx device and things like that. Like, what is that?
Oh, yeah. So Lynx is also great. And I can talk a little bit about what the data is behind these. But so the Lynx is another way of reinforcing the valve. It's a really ingenious device. It's a string of magnets that, like a little bracelet, that we can put around the valve, the weakened valve. And because it's magnets, when you swallow, it opens. But then as soon as the food passes, it snaps back shut because it's magnetic. And so that is going to prevent, after you swallow, prevent anything from being able to come up back into the esophagus. Both of those are the partial fundoplication or the fundoplication and the Lynx device are both addressing the valve in a different way. Same as the endoscopic procedure I mentioned, that also is addressing the valve. And they can help decrease the progression or decrease progression, and which means decrease the chances that Barrett's will go on to esophageal cancer because you're decreasing the injury. But it also can help the Barrett's regress. So just by having an environment where where the esophagus isn't exposed to gastric contents and acid constantly, that Barrett's can heal.
In our prep for this, you mentioned that you had some recent data that would be interesting to share on the show about two groups of patients. Can you tell us a little bit about that?
Yeah, so there's a lot of interesting data, but one of the papers that I found really interesting that really hits home regarding how surgery can help Barrett's patients is a study that took patients that had low-grade dysplasia, Barrett's that's higher risk, and they separated them into a group that underwent surgery. So they either got a fundoplication or they ended up just getting antacid medications. And then they studied how did their Barrett's do in the surgery group or in the medication group. And the patients that got surgery had 80% of the patients that got surgery had regression, or their Barrett's got better, and none of them progressed to a higher stage of Barrett's or esophageal cancer. Whereas the patients with medicine alone, 23% of those patients had regression. So the surgery group did a little bit better. And that's not that surprising if you think about it, because the antacids are helping with the symptoms and are helping with decreasing acid. But if your valve is weak and you have a lot of other gastric contents coming up as well, the surgery fares better at decreasing the total injury. But to that being said, they had no progression in the medication group either. They just had less regression. So it didn't downstage as much. And then there's another paper that looks at Lynx, the little bracelet, the magnetic ring, and what does that do to Barrett's esophagus? And that had about a 60% regression. So Barrett's would decrease in length or in severity in 60% of patients, and none of those patients progressed either. So all of these studies are really showing how surgery can be an adjunct to treatment. It's never going to be the only thing. You're always going to be needing surveillance with endoscopy and possibly some ablation therapy before or after surgery. But it really helps to prevent the injury and help prevent the injury long term. And so that's really exciting because we can help so many patients if we can restore their anatomy.
No, and this is, you don't hear too much about Barrett's esophagus and GERD and the relationship. So this series has been phenomenal. Really sets a nice foundation for patients to start the conversation, to really understand in themselves. I think we always hear about, IBS and other things that are more common and people talk about more. But I really appreciate what you and the other experts have done here to bring attention to this really important health topic. I'm sure our listeners are thinking the same thing. How do you know what to do? Like, how do you decide between medication, lifestyle modifications, and surgery?
That's really a discussion with your providers. And I think it's really important to work closely with your providers. I think acid reflux is so prevalent in every other person you talk to is like, oh yeah, I take Tums or I have acid reflux, and the medications are so easily to get your hands on at the drugstore that I think patients maybe don't understand the severity. So the first thing is talk to your doctor about acid reflux. Make sure that you're not having the risk factors for Barrett's or you don't have injury. And then it's going to be probably a stepwise approach. But I think it's important that you know all your options. You know that part of it is going to be medication, part of it is going to be lifestyle changes, and then you may need an ablation therapy or an endoscopic EET, and then surgery may be a part of that algorithm too. And if any part of that is missing in the discussion, so you need to seek that out. So if your surgeon doesn't talk to you about your endoscopic options or your GI doctor isn't talking about your surgical options, you need to understand that it's really all four that need to be discussed so that you know that you're getting all of the options and you're going to have the best results. And with those conversations, then we can really pinpoint what's going to be best for you on an individualized basis.
Dr. Houghton, thank you so much for your expertise and for helping us understand the many options available to patients who are diagnosed with Barrett's esophagus. Your clear explanations and focus on personalized care truly empower patients to take actionable steps and work closely with their care teams. In our next episode, the final in this series, we'll walk patients through what happens after diagnosis or treatment, including long-term monitoring, follow-up care, and how to stay proactive in managing their health over time. And a big thank you to Castle Biosciences for sponsoring this special education series.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.